how much of this sort of uh, activity in the PBM area is a consequence of the shift from what is commonly called traditional drugs to specialty drugs? And are those two trends related?
That's kind of the crystal ball that I think is hard for anybody to comprehend. I'd look at it a couple different ways. One, everybody keeps talking about cell and gene therapy, and by 2027, with that, massive approvals that it seems like are coming out of the FDA pipeline, that could be $100 billion. Now, the reality is most of that 100 billion is going to go to the medical side because PBMs are not going to be approving cell and gene therapy drugs, right? So that doesn't impact our sales, whether some people are including that number in our sales or not. Second, then on the specialty piece, I don't know if this, I think it continues to go up, right? But let's look at Humira, right? It's going biosimilar 2023. You've got 11 different companies now with approved biosimilars, several that are bioidentical, that are going to hit the market. So while Humira is $22-24 billion in sales this year, what does that drop to with Stelara right behind it? A couple more of these blockbuster, biologic products than having generic competition. I think that'll be interesting to see. But, I think that takes the specialty curve from here to here. I do think what we see out of the traditional PBMs is I think nobody ever looks at that generic spend anymore. I think they just assume they have to focus on specialty. But we're seeing a ton of gamesmanship now occurring on the generic side, which is driving up costs significantly for self-funded payers and the American public. So I think, to me, if you were going to ask why the pharmaceutical market was going to have the continued expansion and revenue that it's got, it's because people are going to play games in the middle to drive up costs, which the American public's going to foot the bill for.
And when you say people are playing games, you're talking about PBMs?
Absolutely, yes.
And what sort of games are you thinking of?
I mean, whether we talk about, are you tracking Qualant, Express Scripts' new, purchasing entity that's based in the Grand Cayman Islands, why Express Scripts feels it needs to own purchasing, I think is interesting, especially because they continue to say this is about leveling out the supply chain for products that have been unlevel. But all the products they've got, none of them have had a recall in years, if not decades. They're all very standard products. They're super easy to come by. There's tons of manufacturers. So, I think that's a problem. We did testimony to the Kentucky state legislative policymakers here where we said, hey, look, there's publicly available data the state of Kentucky has. One drug, rosuvastatin, state's paying $290 a fill. Look, you can find it for $7 if you have no insurance. So how is your PBM using their size to, make drugs more affordable for your members when they're doing these things, right? So, I think we continue to see, other PBMs really overprice how they look at HIV drugs and how HIV drugs are considered specialty, but, so they're getting a lower discount versus a brand or generic discount. So it's just, creating bad formularies, moving drugs around and doing things that nobody's really paying attention to.
I just want to unpack that HIV comment. So could you just go over that for me? They classify HIV drugs as specialty drugs, and that has a consequence on the discount?
Yes. So like generic Truvada right now, HIV PrEP drug, we see it in clients' claims files anywhere between $1,000 and $1,500 a month. So, the PBM says, here's the AWP of this generic Truvada. Well, if they term it as a generic based off of their contract with a client, they'd have to give it, say, an 85% discount. So, if it's $1,000 AWP and I've got to do an 85% discount, I'll charge $150. Well, that same contract, though, says for a specialty drug, I'll give you maybe a 20% discount. So when the PBM can say, well, Truvada is an HIV product, is a specialty drug, and I'm going to have you send it through my specialty pharmacy, I'll charge you $800. Maybe I'll even charge you $750 because I'm such a nice PBM. So I got you 25% discount off of it. But then the reality is, like Mark Cuban Cost Plus Drug Company, I can get a 30-day supply of that for $15. So if Cuban can buy it for 15, something tells me these massive PBMs can buy it for a similar price. And then when they're charging people significantly more for those products, It is a way to create pools of profit for themselves and not drive down better affordability.
And they charge that high price, that high net price, because because the contracts are written that specialty drugs are discounted less than the traditional drugs vis-a-vis generic. So it's the classification of the HIV drug as a specialty drug that creates the high price.
Yes, and thing is, there is no industry standard, right, for a specialty drug. So you could say, hey, I use Metaspan or First Data Bank. Here's brand and generic, right? Like you could pretty much come to an industry agreed definition on brand and generic. I mean, there's still some fuzz in there, but you could make it happen if you wanted to. Nobody's ever tried to say this is a specialty drug, this is not. So everybody gets to create their own specialty drug lists. And because that's not part of the contract, it's just, hey, I'm your PBM, I'm going to make the specialty drug list, but here's your discounts and guarantees off of that. Cool, there you go.